I'm Gwen White, and I have the privilege of being one of the co-leads of the efforts at the Southwest Mental Health Technology Transfer Center, supporting your work with youth and young adults of transition age. The Pacific Southwest Mental Health Technology Transfer Center is part of SAMHSA's network of technology transfer centers. The Pacific Southwest MHTTC serves the mental health workforce in Region 9. That's Arizona, California, Hawaii, Nevada, and the Pacific Islands, including America, Samoa, Guam, the Marshall Islands, the Federated States of Micronesia, Northern Mariana Islands, and Palau. Region 9 offers a collaborative model to provide training, technical assistance, and resource dissemination for the work you do. That includes information pertaining to young adult services and support. And the goal is to promote strategies that support you as providers and practitioners. Here's some of the things that are provided. Obviously, this is a webinar. There's also a monthly newsletter in which there is a whole section devoted to youth and young adult services and support. So please make it a habit of looking at that monthly. As I told you earlier, I'm Gwen White. I'm facilitating today's call. Kristen Thorpe and I co-lead the efforts around youth and young adults for the center and nationally. She will be presenting today along with Amanda Lipp. I've had the privilege of working closely with both of them, and you are going to enjoy the expertise and information that they bring to us. They're going to be introducing themselves, so I'm going to turn it over to you, Kristen.
Great. Hi, everyone. This is Kristen. I am the project coordinator for Youth Move National. I'm a little bit of a jack of all trades at the organization and fill in where I can, and I've been really happy to be doing this work with Gwen for the MHTTC for the Southwest region.
And hello, everyone. Thank you for being here today. My name is Amanda Lipp. I work for the Center for Applied Research Solutions as a technical assistant specialist. I'm also a filmmaker in the mental health field and an advocate sharing my story, which you will hear a little bit later.
This is Kristen again. Today's learning objectives are going to be to understand the history of civil commitment in the United States, consider some of the standards for civil commitment and involuntary mental health treatment, identify some best practices and practical strategies for shared decision-making with youth and families throughout a civil commitment process, and finally, to identify some key questions for policy and agency decision-makers to consider when they're establishing processes that might lead to a civil commitment. So before we get started, I think it might be helpful to define some of the various types of civil commitment that might be experienced by those who have serious mental illness. Involuntary mental health treatment occurs in a variety of contexts, although the most common is inpatient civil commitment or an involuntary hospitalization, depending on what you're familiar with. And an inpatient civil commitment is a legal intervention by which a judge or someone acting in that judiciary capacity may order a person with serious mental illness who meets specified criteria to be confined in a psychiatric hospital for a certain period of time. This often follows an emergency evaluation, which is a crisis response in which a young person or a young adult is admitted to a facility for psychiatric evaluation. And that's typically a time-limited period, for example, a 72-hour hold. Inpatient civil commitment is practiced nationwide. However, the standards that qualify an individual vary significantly from state to state. Involuntary inpatient chemical restraint describes the use of a drug or medication to restrict or manage a person's behavior and or their freedom of movement. Chemical restraints include sedatives or antipsychotic drugs. And while a person may already be using these types of medications to manage their illness, the use of chemical restraints indicates that you're going beyond their kind of standard treatment or dosage. Electroconvulsive therapy, or ECT, can be a really effective treatment primarily for individuals who have severe depression or some acute psychotic states and mania. However, there are really some potential adverse side effects, including memory loss and other cognitive damage. And some people experiencing extreme symptoms of serious mental illness may be unable to give informed consent because they are lacking judgment in that moment to adequately weigh the risks and benefits. And to address this, clinicians and policymakers should really ensure access to enforceable advance directives and a process that has adequate procedural safeguards. Restraint and seclusion are behavioral management interventions that should be used as a last resort to control an emergency situation. Restraints include the use of physical force, mechanical devices, or chemicals to immobilize a person. Seclusion, a type of restraint, involves confining a person in a room from which the person cannot exit freely. Forced seclusion and mechanical restraint are intended to protect young people and those around them, but the use of these measures restricts freedoms and really conflicts with the ethical principle of patient autonomy. These coercive measures also present risks due to their side effects and are even more problematic when used repeatedly or in combination. So, for example, using seclusion or forced medication combined with physical or mechanical restraint. And it can be extremely traumatic, causing physical and psychological harm to both young people and staff. Outpatient civil commitment is a relatively modern trend in the U.S. In contrast to inpatient, which involves separation of a young person with serious mental illness from society completely, outpatient civil commitment allows people suffering from mental health challenges to remain in their home communities. It's an alternative means of mandating the treatment of individuals who could potentially become dangerous to themselves or others without forcing them to be hospitalized. Like inpatient civil commitment, outpatient civil commitment depends on several criteria, including a diagnosis of serious mental illness, a clear need of treatment, and a history of treatment non-adherence, and also an indication that voluntary psychiatric treatment is unlikely. Finally, there must be evidence indicating that the young person is likely to decompensate into a state that would prove dangerous to him or herself or others if non-adherence were to occur. If these criteria are met, the young person can be mandated to outpatient psychiatric treatment, however, not necessarily forced to take prescribed medication. In some cases, though, outpatient civil commitment is used to compel the use of medication. The criteria for involuntary medications vary from state to state, but commonly include such aspects as incompetence to participate in decisions about treatment and expected clinical deterioration or dangerous behavior to self or others without the medication. Court-ordered involuntary medications are time-limited, often lasting only as long as the young person's civil commitment or for a period set by a judge. Extension beyond that time requires a reappraisal of the use condition, their response to treatment, and likelihood of future compliance. And finally, while not involuntary in the eyes of the law, it's important to remember that much of psychiatric treatment is, in fact, undertaken on behalf of individuals who consent to treatment under the subtle or direct coercion of families, friends, and or employers. This is especially the case when young people may feel they have limited options. So, for example, if parents or caregivers make threats about withholding resources or other things that may be of value to a young person. So there's a long history of civil commitment in the United States, well, and actually worldwide, but for our sake, the U.S. So in colonial times and early years of the United States, there was little formal legal regulation of care for individuals who suffered from mental illness. Those with mental health challenges who could not care for themselves were typically ignored or managed in jails or poorhouses. This served purely as containment or punishment, and no therapeutic efforts were made. In 1773, Eastern State Hospital, which was formerly known as the Public Hospital for Persons of Insane and Disordered Minds, opened in Williamsburg, Virginia. It was the first public facility built with the intention of solely treating patients with mental illness. The treatments available at the time were restraint, strong drugs such as bromides and chloral hydrates, plunge baths and other shock water treatments, bleeding and blistering salves, as well as electrostatic machines. Between 1817 and 1824, 4 privately funded asylums were established in northeastern states of Connecticut, New York, Massachusetts, and Pennsylvania. And subsequently, public institutions were opened in the southern United States, and the widespread establishment of state-run facilities soon followed, in part due to some Reformation efforts led by Dorothea Dix. Reformers shone light on the poor conditions under which so many people with mental illness lived and advocated for the development of residential facilities for their care. These efforts led to the establishment of 110 psychiatric hospitals by 1880. However, admission criteria, to the extent that they were actually articulated, were simply that the person needed or would benefit from treatment. So typically this would mean a family member would propose admission and a physician would certify the admission for an indefinite period of time. In response to some of these abuses of civil commitment, 20th century America saw a shift in the standards for involuntary hospitalization. States changed civil commitment laws to put legal protections in place to protect the right to liberty of a person being considered for commitment. These legal protections included the potential inpatient's right to a trial with attorney representation prior to a psychiatric admission. Stricter commitment standards were imposed, and the decision-making power was taken from the hands of medical professionals and placed in the hands of judges and magistrates. Despite efforts to curb the overuse of civil commitment, populations in American institutions swelled to more than 500,000 during the 1950s, with an all-time high of 559,000 psychiatric inpatients in 1953. In 1951, the National Institute of Mental Health published the Draft Act governing hospitalization of the mentally ill. The Act functioned to restore psychiatrists' decision-making power on the issue of civil commitment to its prior state, unburdened by lengthy legal procedures after psychiatrists and mental health advocates protested stricter commitment standards, which they saw as extreme and harmful to patients. During the same time that the NIMH was successful in advocating for a public view of commitment as a necessary step to treatment, new medications were invented that challenged the assumption that institutionalization was actually necessary for the care of people who have mental illness. In 1954, the first antipsychotic drug, marketed as Thorazine, was approved by the Food and Drug Administration. It quickly became a staple in psychiatric facilities and was actually so effective in treating certain types of psychosis that the idea of community-based outpatient treatment, which was previously considered not possible, actually seemed possible again. So less than a month before his death, President John F. Kennedy signed the Community Mental Health Act, which provided $150 million of federal funding for the construction of community-based preventative care and treatment facilities. Unfortunately, between the Vietnam War and an economic crisis, the program was really never adequately funded. And with the passage of Medicare and Medicaid in 1965, states were incentivized to move patients out of state psychiatric hospitals and into either nursing homes or general hospitals because the program excluded coverage for people in institutions specifically for mental illness. As a result of some of these factors, deinstitutionalization began, and huge numbers of state hospitals were closed across the country. In 1967, California enacted the Lanterman-Petrus Short Act, or LPS Act, requiring for commitment either imminent dangerousness or grave disability, which is defined as a condition rendering a person unable to meet his or her basic needs for survival. And this served as a model for other states considering reform of their commitment laws. And by the end of the 1970s, practically every state had revised its commitment law to require dangerousness or some condition akin to dangerousness as grounds for commitment. Each state's civil commitment criteria also still reflects standards set forth in an important Supreme Court case, OConnor versus Donaldson, which was in 1975. This case involved a man named Kenneth Donaldson who was diagnosed with paranoid schizophrenia and was held in a psychiatric hospital against his will for 15 years. When his release was repeatedly denied by the psychiatrist in charge of his care, despite the fact that he hadn't shown any evidence of suicidality or intentions to harm others, Mr. Donaldson argued to the court for restoration of his freedom. The case was eventually heard by the Supreme Court, who determined that Mr. Donaldson should be released. The U.S. Supreme Court upheld the verdict in Donaldson's favor, ruling a state cannot constitutionally confine without more a non-dangerous individual who is capable of surviving safely in freedom by himself or with the help of willing and responsible family members or friends. In 1980, President Jimmy Carter signed the Mental Health Systems Act, which aimed to restructure the Community Mental Health Center program and improve services for people with chronic mental illness by increasing and strengthening links between local, state, and federal government. However, in 1981, under President Ronald Reagan, the community legislation was repealed through the Omnibus Budget Reconciliation Act, leading to major service reductions. Reagan instead established block grants for the states, ending the federal government's role in providing services to those with mental illness. The block grant system redistributed money to the states, but in much smaller amounts, which increased the burden upon local and state governments. Overall, federal mental health spending decreased by 30%, By 1985, the federal funds provided via block grants covered only 11% of agency budgets, while state responsibility grew to 42%. Though deinstitutionalization began with the advent of psychotropic medications and changes to Medicaid laws, which denied funding for inpatient services, ongoing budget cuts throughout the Reagan administration continued the trend. In 1990, the FDA approved clozapine, the first atypical antipsychotic drug to be developed. And by 2004, studies indicated that approximately 16% of prison and jail residents were seriously mental ill, so roughly 320,000 people. And during that same year, there are about 100,000 psychiatric beds in public and private hospitals, which means there are more than 3 times as many seriously mentally ill people in jails as opposed to hospitals. In 2009, in the aftermath of the Great Recession, states were forced to cut $4.35 billion in public mental health spending over a period of 3 years, the largest reduction in funding since deinstitutionalization. By 2010, there were 43,000 psychiatric beds in the United States, or about 14 beds per 100,000 people, which is the same ratio as in 1850. And that gets us to today. So in a mental health crisis, people are more likely to encounter police than they are to get medical help. As a result, 2 million people with mental illness are booked into jails each year. Nearly 15% of men and 30% of women booked into jails have a serious mental health condition. The states with less access to mental health care have more adults who are in the criminal justice system. 6 out of 10 states with the least access to mental health care also have the highest rates of incarceration, highlighting the importance of investing in community-based mental health care. So the state's authority to commit individuals stems from 2 legal theories: parens patriae and the police power of the state. Parens patriae, which literally means parents of the country, provide the authority to protect citizens who, for reasons of mental or physical disability or because they are unsupervised minors, cannot adequately protect or care for themselves. Interventions by the state is indicated for individuals who are deemed unable to make rational decisions for themselves, including those who are considered gravely disabled or suicidal. The state also is obligated to make the decision that is in the best interest of the individual and most clearly reflects the choice that the individual would have made if he or she were competent to do so. The legal theory of police power provides the state with the authority to act for the protection of society and the general welfare of its citizens. In the process of such protection, isolation and confinement of dangerous individuals may be necessary. So, for example, when a person with mental health challenge is deemed a risk to themselves or others, or to the others rather. Whereas parens patriae provides for the protection of the individual, police power generally is invoked on behalf of society against the individual. The legal standards specifying the criteria for civil commitment, as I mentioned, vary widely from state to state. However, there's a few that are pretty consistent across the board. The first standard, which is required in every state, is the presence and diagnosis of severe mental illness, which usually excluding substance use disorders, intellectual disabilities, and dementia. Dangerousness to self or others is another standard for civil commitment and appears in the law in nearly every state, although no longer is an exclusive criteria in most. As previously discussed, this means a person is at imminent risk of carrying out plans of harm, either to themselves or others. Grave disability is also a standard. This is part of the law in most states and is generally defined as an inability to provide for basic personal needs. The need for treatment is required in nearly state as well, either as an explicit criterion or as a part of the definition of mental illness. The same disorders that impair a person's moods, thoughts, and functioning also impair his or her insight and judgment, making refusal of care common in psychiatry. In these cases, psychiatrists face the challenge of weighing their professional obligations of non-malevolence and beneficence in deciding whether hospitalize patients against their wishes. It's also important to note that at times a lack of community-based care can be factored into a civil commitment process. Another consideration is deterioration. This is beginning to appear as a distinct criterion in some states' laws or as a part of the definition of grave disability, although it's never an exclusive criteria. And finally, incompetence is part of the law in a few states. This is never an exclusive criterion. Incompetence is considered when an individual suffering from mental health challenges is unable to make rational and informed decisions. Certain mental health diagnoses affect the prefrontal cortex, So for example, like Alzheimer's disease, schizophrenia, and bipolar disorder affect the prefrontal cortex, which is an area that's essential to insight and understanding. Some medical professionals feel that many people with severe mental illness may lack the self-awareness to understand and follow treatment recommendations, and therefore that these individuals' outpatient commitment may be an appropriate solution. Which gets us to ethical considerations of civil commitment. So whether it's justifiable to treat patients against their will, and if so when, is a central question in medical ethics and law. Mental health advocates highlight the need for the judicious and limited use of involuntary psychiatric care. The process should be used as a last resort after every attempt has been made to thoughtfully engage young people in accessible, comprehensive, community-based care on a voluntary basis. It is important that every effort is taken to provide care in the least restrictive setting because of the impacts an involuntary hospitalization can have. One potential outcome of civil commitment is damage to the therapeutic relationship between a doctor and youth or young adult of transition age. The loss of trust of a provider may make a person struggling with mental health less likely to seek care in the future or continue with recommended treatment. Involuntary commitment, whether associated with hospitalization or a community and treatment program, involves a significant limitation of liberty, the kind of limitation that is rare outside of the criminal justice system. For this reason, among others, commitment remains controversial, especially among recovery-oriented mental health stakeholders who place a high value on personal autonomy and self-determination, which is a central principle in contemporary healthcare. Mandating treatment is inherently coercive, and that coercion on its face is antithetical to self-determination. Thus, court-ordered treatment requires a really strong justification. The process of civil commitment and losing one's autonomy is inherently traumatic as well. Additionally, the use of seclusion and restraint continue to be used in inpatient commitment settings, and the experience can be highly traumatic for some young people, especially those who have been victims of sexual assault or other violence in the past. Compulsory admission to psychiatric inpatient treatment can be experienced as disempowering and stigmatizing for people with serious mental illness. Such stigma is really unsurprising when viewed in light of how serious mental illness and mental health hospitals are portrayed in popular culture. So think One Flew Over the Cuckoo's Nest or the more recent show American Horror Story Asylum. It's also important to note that racial and ethnic disparities are as widespread in the diagnosis and treatment of mental illness as they are in other areas of health. In 2001, then Surgeon General David Satcher issued the report Race, Culture, and Ethnicity in Mental Health, in which he convincingly documented disparities in access and treatment that leave too many minority individuals untreated or improperly treated. Lack of access to unbiased and culturally sensitive treatment has real consequences. According to a study by Barnett et al., ethnic minority communities, particularly Black ethnic groups, are more likely to be involuntarily admitted to hospitals compared to those with white ethnicities, and they also experience an increased risk of readmission. Now that we've explored some of the standards for civil commitment and some of the ethical tensions associated with that process, we'll discuss some of the best practices and some strategies for shared decision-making with youth and young adults during an involuntary hospitalization. So what is shared decision-making? According to SAMHSA, shared decision-making is an emerging best practice in behavioral and physical health that aims to help people in treatment and recovery have informed, meaningful, and collaborative discussions with providers about their healthcare services. It involves tools and resources that offer objective information and allows youth and families to assess the potential benefits, risks, and costs of various treatment options. Those options are then discussed and considered collaboratively among providers, families, and youth. Mental health literacy is defined as knowledge and beliefs about mental disorders which aid their recognition, management, or prevention. It's made up of several components and is focused on better equipping people to overcome structural barriers to health and to tackle both stigma and discrimination. Components include the ability to recognize specific mental health problems, knowledge and beliefs about risk factors, self-management approaches, and the professional help available, knowledge and beliefs about self-help interventions, attitudes which facilitate recognition and appropriate help seeking, and knowledge of how to seek and access mental health information. The first step in preventing a civil commitment is to encourage and improve help-seeking behaviors and the ability to identify symptoms of mental illness. Personal autonomy and self-agency are respected by listening carefully to individuals who are subjected to commitment and honoring their treatment preferences to the extent possible, especially when their wishes are documented in competently prepared legal advance directives. Respect and protect the dignity of youth and young adults throughout every step of the civil commitment process. This includes incorporating youth-driven practices like providing developmentally appropriate services and support and providing space for youth to have voice and choice in their treatment planning. And the young person in crisis is assisted to be in the least restricted setting to resolve the crisis, whether or not they are committed. Similarly, person-centered approaches should be integrated in order to meet a youth or young adult's needs. This includes incorporating shared decision-making that honors hope, trustworthiness, engagement, and collaborative treatment. It's also important that relevant information should be clearly communicated to the young person about their commitment status, the purpose, process, reevaluation, criteria for ending their commitment, risks and benefits of treatment, and legal issues, including the right to appeal or refuse treatment. And it's also critical to clearly communicate this information and understand what a young person is to expect. The duration of commitment should be limited to as short as reasonably possible to restore the youth or young adult to the capacity to participate meaningfully in beneficial treatment in a community-based setting. This is important because involuntary hospitalization and treatment can have the unintended adverse effect of reinforcing and increasing the social stigma associated with mental health issues. Ensure that due process and protections are understood and employed at every level for the young person experiencing a civil commitment, and restrict the use of interventions such as seclusion and restraint. They really should only be used as a last resort to ensure the safety of both the young adult and staff, and it's essential that there's explicit policies and procedures developed to minimize their use. Consider any trauma history that the young person may be coming in with to minimize the risk of re-triggering that trauma. And as previously noted, this is especially important when one is considering the use of restraint or seclusion. And throughout and following the commitment process, the youth's individual strengths should be determined, recognized, and incorporated into treatment and recovery support services. When possible, involve supportive family and friends, identified by the young person, as long as it's consistent with their rights and their consent. And it should perhaps go without saying, but it's also necessary that all persons involved in the commitment process should be free of material conflict of interest. Now I'm going to hand it over to Amanda to share a little bit about her story and contextualize some of the information that I've shared so far.
Excellent. Thank you so much, Kristen, for that historical overview. It's really quite a fascinating and complex topic, and I'm really glad that we began with that foundation, so thank you. And I'm really happy to be sharing my story with you all today as it relates to civil commitment. I'll just introduce myself again. My name is Amanda Lip. I work for the Center for Applied Research Solutions as a technical assistant specialist. I'm also a filmmaker and a speaker sharing my story about mental health and making films about youth mental health as well. So I consider myself really a storyteller, an advocate, an artist with lived experience of experiencing the mental health system as a young adult. Now I'm 27, but it feels like yesterday when I was committed to the system, and I really live by that every day in the sense that trying to improve the system and be part of the solution of the system. So with that said, I'm going to share what my story was being committed to the system and how I recovered and was able to transition out of the system and work now in mental health, share my story, and pay it forward as well so other youth, young adults, and also the caregivers as well can have more support as they go through this process themselves. So with that, I'd like to just start with going back in time when I first experienced my mental health breakdown. This right here is a picture of me when I was in active psychosis my freshman year of college. So I was 18 years old, I was a freshman, and I had just left high school, and the safety net of my parents' home was trying to figure out what I wanted to major in, what social group that I wanted to belong in, the campus clubs, and all of that relatively normal college experience stuff as an 18-year-old kid. And what most folks, my friends, my new peers at this brand new college campus didn't realize, and neither did I, was that I was actually experiencing psychosis in this picture. And I was hearing voices, I was seeing things that weren't real to anyone else but me. And my friends thought that I was actually overdosing on drugs at one point. and did not know the symptoms of psychosis or mental illness at the time. And they rushed me to a psychiatric hospital facility, otherwise known as a PUF unit, nearby. And that was when really my journey began, being in the mental health system, which kind of became like a rabbit hole in Alice in Wonderland, where it was sort of this never-ending process of trying to navigate and figure out how to get well and how to find Amanda's self again. It's really kind of hard to find the words to describe what psychosis felt like, but this picture I found kind of describes in my mind sort of the black hole or the abyss, if you will, of psychosis, and sort of losing my mind in those moments and being in my own world. And some folks may have seen this movie called The Truman Show. It's actually quite a common experience for folks with psychosis or with different hallucinations or delusions to have what's called the Truman Show effect, where you think that the world is watching you and you're part of this sort of larger TV show. And for me, it caused a lot of paranoia, but also inspiration, because I was really believing that I was part of something greater than myself, and that this was really, there was a purpose attached to it. I had a very euphoric and happy and manic psychotic experience, and I was in the state for about a week during college on campus, just kind of slowly spiraling into the state where I gave away all of my money. I dropped out of college, thankfully on a medical leave of absence, so I had a way to come back into the school system and hopefully one day be able to graduate. But at the time, I wasn't able to think beyond the fact that I was in this Truman Show euphoric land of the world, and I couldn't see beyond that. And that was really when I entered the system, the mental health system, and was civilly committed. Going back to Kristen's definition, I was in inpatient civil commitment. So I was involuntary committed into the psychiatric hospital. So I was put on a 5150 72-hour hold. That was the initial hold. And in California, as Kristen mentioned, that is the Lanterman-Petras Short Act. So I was considered a danger to myself, a danger to others, and gravely disabled as well. Those are the three criteria that held me at the hospital, and I was given that 5150 hold. I didn't meet those basic needs of being able to take care of myself. And this is really a visual. As an artist, I try to find visuals that can describe what it felt like to be committed into the mental health system as an 18-year-old kid just trying to figure out life. And here I am now entering this system that felt like it was a never-ending tunnel of being diagnosed and being told that I'm mentally ill now. And a minute earlier, I thought that I was just struggling to find the right major in college, and now here I am in a mental health hospital being held against my will on a 5150 hold, being told that I have bipolar disorder, that I might be schizophrenic, that I have clinical depression, psychotic-induced psychosis, and all these different symptoms and diagnoses you can imagine as an 18-year-old kid. It's really hard to hear those things, especially when there is the historical stigma and systemic injustice attached to all of these different diagnoses or identity markers. And so that was really kind of what it looked like in my mind, being committed to the system. And going back to the ethical considerations that Kristen was touching upon, the personal autonomy, sort of the impact of being committed on the therapeutic relationship between the doctor and the youth, I want to tell you a little story about a nurse in the system who noticed that I wasn't doing well. It was a system at this psychiatric hospital where it was a lot of shuffling of folks around between ICU, inpatient, outpatient. There weren't a lot of resources for different therapeutic activities like art. It was a very dry, sort of stale environment where for me as an artist and as someone who's very expressive, I really didn't feel like I had an outlet to voice my trauma or to draw or express my challenges, my adversities, or my story, and what even happened to me to get to this place in a visual narrative. And so it wasn't really until a nurse noticed that I wasn't doing well and took it upon herself to walk over to me and hand me a box of crayons. And this was when my life changed. And when crayons became, and to this day, almost 10 years later, a tool that I continue to use to voice myself, to have that personal autonomy, to use as a medium to communicate between myself and my providers, my family, and just as a cathartic outlet to express my feelings and to reduce the anxiety or the depression that I might be feeling. And so this nurse handed me the box of crayons, and it became the saving treatment that allowed me to communicate with the doctors. And I actually began to respond better to treatment. But most importantly, I felt like I had a sense of agency. I felt like I had a sense of worth, that someone noticed that I had something to offer and that it was something creative as well. So I began drawing with these crayons, this layering etching technique that really became a way to visually draw the trauma that I had experienced when I was younger, all the way through psychosis at this point when I was in college. And it gave me a roadmap to wellness, really, and allowed me to depict who I thought I was, who I wanted to be, and sort of the evolution of my sense of self while I was in this hospital system. And it allowed me to also begin to reconcile between not only trauma, but then also opportunity and who I wanted to be and what vision that I had for myself. And that I didn't have to feel civilly committed, that this was a sentence for life or a label for life, but that this was something that I had choice over. This simple box of crayons gave me that dignity, that autonomy, and also gave me trust. Now that I had an ally in the hospital, this nurse, it gave me a bridge to feel like, you know what, there is someone here that notices what I'm going through and was able to be insightful enough to hand me just the simplest tool. I mean, a box of crayons, it's affordable and it's a non-dangerous tool. The reason we actually had crayons in the hospital is because you can't hurt yourself or others with crayons. So also just going to a systemic resource side of things, it doesn't take a lot to have a big impact on someone's wellness. A box of crayons isn't that expensive, and it made a huge deal on the rest of my life. And what I like to call this crayon etching layering process, later on when I was discharged, I was able to reflect on what that meant to me. And this was sort of a psychological sort of archetype, if you will, about what the crayons meant to me in terms of how I communicated my wants and my needs. And this goes back to the theme of civil commitment with self-agency, identity, and self-dignity, self-worth. And of course, how these expressive tools can give someone a space to understand what this civil commitment might mean for them. So this expression wellness journey, it began with access, right? The crayons was a form of access. I was given a tool to express myself. And then from there, I was able to reconcile between pain and trauma, and then finally opportunity, being able to see the light at the end of the tunnel and know that I didn't have to be in this hospital forever, that I actually had worth and I had value to offer. And that was what gave me hope. I began to draw in color. I began to see that I had purpose beyond the system. And really, I began to see that there was something to live for and that I wasn't just a product of the system or that I was stuck in a revolving door, but that I really had a sense of ownership over what I was feeling. And then the peer-to-peer aspect as well was really important. So in the hospital system, there were a lot of folks around me who also had different mental diagnoses and experiences, trauma, and were also civilly committed to the system. So we all had various forms of 5150, 5250, and it was really interesting and like the social experiment. I almost, as a patient, had to see it as a social experiment because it was such an interesting process and system to observe, not only as a patient, but as someone trying to beat the system as a patient too. And it was interesting being on multiple 5150s, so multiple 72-hour holds, and sometimes even a 5250, which is a 14-day extension of that 72-hour hold. So I was in the hospital for many, many weeks, revolving between 5150s and 5250 holds, watching and observing myself, but also the other patients going through this cycle. And it didn't seem like any of us were getting out. It seemed like we were just kind of always going through this revolving door. And the complex part about my story, which I think is common for a lot, was that I was 18 years old, so I was an adult. I technically had rights and was able to make decisions for myself. However, I was still involuntarily held at this hospital because, of course, I met those standards for being a danger to myself, others, and gravely disabled, in that I wasn't able to take care of myself and those basic needs of food, shelter, and finances and things like that. And every 3 days, as part of being on the 5150 and 5250, I would have a certification review hearing. And so that is where someone like a peace officer, for example, or sort of like playing that role of a social worker would come in and would interview me. And the point of that interview, of that certification review hearing, was to make the determination if I was able to be released immediately or if I needed to be on another 5150 or another 5250 14-day extension. And this was like every 3 days basically having a mental tryout. So being able to try to prove to this person who I don't even know if I'm mentally fit, mentally able to be released back into the community, and was basically mentally well, even though I'm told and that I was mentally ill. So it was difficult from a philosophical perspective as an 18-year-old, hard to reconcile between trying to be and act mentally well when you are there because you are mentally ill and told you will be forever. That was at least the verbiage that they told me then, and that was the culture at the system that I was at the time, that this was sort of a lifelong trajectory I would always be on, which now isn't the case. I'm very mentally well, and that goes back to the stigma and sort of the trust and the nuance of language and the importance that caregivers and providers are mindful about the choice and the shared decision-making and identity discovery as part of mental health and mental illness. I think a big reason why I was in the hospital for so long is because I was so philosophically confused about the definition of what it means to be mentally ill and how that affects identity and who I am. Do I call myself Amanda now? Do I call myself a mentally ill person? Just those really just deep core identity questions when you're already at the transitional age where you're trying to figure out life anyways. And so these crayon drawings that you're seeing in front of you is a representation of the drawings that I was doing that built up over the course of the hospital experience that gave me a story and a roadmap to bring into the certification review hearings and begin to sort of piece together, here's who I am and here's my story, here's why I think I should be released. And self-evaluation is a tool that I was kind of pieced together from my experience in the hospital, which helped me stay out of the system once I was discharged from the system. And self-evaluation is a principle and a theory that I like to sort of use in terms of how to negotiate between self and society. So how to understand what this mental illness means once I'm discharged from the system, and how do I talk about it with friends and with family, and how do I understand that there's social stigma and public stigma out there, but also self-stigma, so what I think and feel about myself. And so I developed this self-evaluation sort of graph to chart the highs and the lows, the mania, the depression, and all the different symptoms basically, and begin to try to translate that into something that was able to be understood by myself, and so I could avoid the system in the future. Or if, God forbid, I was readmitted into the system, I would have documentation of how I got well and what language I used and what strategies and tactics I was able to apply in the certification review hearing, so I was able to get off of a 5150 or be discharged from a 5250 extension. And not to say that, well, if I'm being perfectly honest, I was trying to, in some ways, pretend that I was mentally well or that I was able to be fit. And that was the really difficult part of that, is how to define what that means for oneself. And the complex part, too, if we think about the caregiver role, my parents, for example, so even though I was 18 and I was technically an adult and I had those rights, my parents were part of the certification review hearing in the sense that they were communicating with the doctors what they were able or not able to provide as my caregivers. So on one hand, my parents and I are negotiating what rights or what privileges I would have at the home if I were to be discharged. And on the other hand, I'm negotiating with the system my mental wellness without my parents in the room. And so my parents sort of gave me an ultimatum, and they gave me different sort of incentives. As parents, they were trying to do what was best for me and what they thought was best for my wellness. And at some points, I think parents know what's better for their kids more than the kids themselves. In my case, my parents knew that I was not fit to come home, even though I thought that I was. So my parents told the system, the doctors, that they would not be providing a home, shelter, food, those basic needs to meet the criteria to be released. And that actually made my case worse and made me such that I was not able to be discharged. And I think that's a really important key factor right there, because it's the complexity between the caregivers and the doctors and oneself. So it was important that I had all my ducks in a row for my being able to be released from the system. And so it was a little bit tricky, but ultimately, once I was well enough and my parents were able to also see that I was well enough, then they made the case to the hospital, yes, now we can provide a home, now we can provide food and shelter, which gave me extra points on my certification review hearing to be released. So it's sort of this trifecta of negotiations between me, the family, and the system, which is often the case when you're on that transition age youth sort of border when you don't have typically the finances or the means to be on your own, even though you're technically 18. Mental Mad Libs, this is kind of just a fun way when I was discharged to try to find a narrative for what this experience was like for me. I had a really hard time understanding what bipolar disorder meant, or schizophrenia, or depression, or anxiety, and all these different labels and diagnoses. And I began to do a lot of research on narrative identity and the mental health system, and I found Mad Libs. And I remembered as a kid growing up in the 90s doing Mad Libs, and I thought they were really fun. And it gave me sort of a scaffolding, a narrative to be able to have choice in what verbs or adverbs or nouns I can maybe describe what it was like being in a psychiatric hospital, what it was like being in the system, going from a college student in one sense and then completely in a hospital and out of college and out of money and feeling like a prisoner of my own mind. And so Mental Mad Libs is a fun reminder for me that I have choice, I have identity. And even though I was told I was multiple diagnoses and multiple things, that I actually have choice of how I can talk about that with my employer, with my friends, with my family, intrapersonally with myself. And I had to remind myself that diagnoses and labels and these words, they're words for symptoms. They're words for symptoms that can change across time and space. And even though I was told I was mentally ill, I had to, for myself, see myself as able to be mentally well and on that path to not being mentally ill. And so that was my mental inner workings, trying to really find who I am. I began this process by formulating an identity word bank on the left. So all these different ways in which we talk about mental illness or condition or issue, and sort of the culture of how we construct those sentences, and the actual illnesses themselves, depression, anxiety, or maybe hearing voices, or schizophrenia, or manic, or mania. And there's all this different lexicon for how we talk about mental health. And it can be very overwhelming. And I was very overwhelmed as an 18-year-old kid trying to figure out not only who I was, but then how I wanted to talk about this experience that I went through, and trusting the authority of doctors and the authority of the system, but then also knowing and claiming and owning the fact that I actually did have rights. And what I think the system could have done better when I was in the system, at least, which was a while ago, and I think a lot has improved since, was giving me a Mad Lib structure and having more of a Mad Lib system where the providers and the doctors provided a culture and space where I could be part of that decision-making and part of the narrative story construction, and not being just told in the first 5 minutes that you have this, you are this, but really it being a journey between the caregivers, the family, and myself, because as Kristen mentioned in her presentation, the trauma associated with being committed to an institution is lifelong. I will always have that memory. I will always have those memories. This is why I created these different tools and different sort of concepts to be able to try to deal with it and claim and reclaim who I was, and that the system doesn't always have it right. And so being sort of a disruptor and hopefully a productive and meaningful way, such that one can live their life in a happy way, but also in a way where they're not going to be backing in the system as well. This is just a picture of my crayon drawings and sort of just the finale of my getting well. And the last thing I'll just share is that once I was discharged and back into the community and re-entered back into college, I was able to find a language to describe to my friends, my family, and those around me what happened. At first, I had a lot of shame. I had a lot of embarrassment. I mean, it wasn't cool, right, to go into the psych hospital when you're 18 years old. First, I would lie and say I was at an internship and I was on the path to becoming a psychologist, which ironically I was. But then, of course, it was the complete opposite. I was a patient of the system instead. But it really was the biggest internship of my life, so to speak, in the sense where as a young adult, I got to see the system from the inside out and try to figure it out and navigate how to pass these certification review hearings, how to not be 5150, how to not be 5250, and most importantly, how to build trust with my therapy team, how to build trust with myself, how to reclaim who I was, to have personal autonomy, dignity, and all of that really helps one throughout their life. So those tools and those lessons I'm very grateful for. However, it was traumatizing, and I hope that my story and the lessons and tools that I've garnered from that experience can maybe potentially help other families or young people who are struggling with their identity and or with the process of the court system as it relates to the hospital system, because it isn't easy and there's not one size fits all. It's very complex, but having more tools in your toolbox, especially creative ones, can really be the little things that make a big difference. And with that said, I'm going to pass it back over to Kristen to continue our presentation.
Thank you so much, Amanda. It was really helpful, I think, to hear your story in the context of what that means, like what it actually looks like in practice and how it can affect somebody, and also just the importance of having someone pay attention to you. Like you said, having just one nurse notice that maybe having a creative outlet would be helpful for you made all the difference in your recovery. So thank you so much. As we move into the wrap-up of this all, there's a few questions that both policymakers and providers or just systems as a whole should ask themselves before considering or during civil commitment process. Have all of the least restrictive solutions been considered? Could involuntary commitment cause more harm than good? Will commitment advance the long-term interests of a young person with mental health issues? And are existing inpatient and outpatient programs just? So this is actually just like a little checklist that I found in a SAMHSA document that I'm happy to share after this webinar. But I think it's just a really nice kind of checklist of the requirements and some of the considerations that need to be thought of and that might be helpful during a civil commitment process. So whether that's inpatient or outpatient, like I said, considering whether without treatment or commitment there's going to be negative consequences or, what the impact will be on the young person experiencing that. So I just thought this was kind of a nice checklist, which is always helpful for a visual person like me. Finally, as an important kind of first step in preventing civil commitment, I'm a really huge advocate of increasing mental health literacy. So youth and young adults need to be aware of warning signs. They need to be aware of the symptoms so that they can actually seek help before they're reaching a state of crisis. It's important to conduct outreach and education in culturally relevant and sensitive ways, especially when you consider working with minority populations who have less access to care historically and also who may experience higher levels of stigma. As providers and organizations and systems, it's also really critical to review existing policies and practices to make sure that they're reflecting best practice approaches and are consistent with the standards and guidelines put forth by respective agencies, by organizations, and really actually by states. And to support youth going through this potentially traumatic process, it's really important to integrate person-centered, youth-driven approaches into your practice. And that means training staff on what youth-driven means. It means training staff on culturally competent care, as well as increasing strategies for outreach and engagement. Youth who are involved in multiple systems can be very system-weary, and they aren't always seeking help in the mental health field. They're often first going kind of into informal places, like they're first seeking help from friendships or from mentors or family friends. They're not necessarily going directly to medical professionals. So I think really increasing ability to engage with youth is a huge step in promoting help-seeking behaviors. And advocating for increased community-based mental health funding at the local, state, and federal level is very important. And I know that can be really hard. We're in a time where we're actually seeing more and more budget cuts to things like mental health, but I think one way to do that is to really leverage existing research that shows that communities who have more access to community-based care actually have lower levels of costly inpatient hospitalizations. Lastly, I think providing opportunity for workforce development. So in order for providers to be able to better support youth and young adults who are experiencing mental health challenges, staff have to have the tools necessary to really help young people understand what their diagnosis means, how they can manage symptoms of that diagnosis, and what services and supports are actually available in their communities so that they're not having to go into a state of crisis. So, and I think that with that, we can go into a question and answer session if anyone has any questions for either myself or Amanda.
This is Gwen, and thank you both, Kristen and Amanda. And please, if people have comments or questions, use the chat box to let us know what those are. I so appreciated both the historical perspective and your willingness to share, Amanda, the personal perspective, and then, Kristen, how you pulled this together. I'm wondering if you each, and it's interesting you have policy and practice up there, Kristen. I was thinking while I listened to both of you, if you could identify a policy or a practice change that would reach the top of your list or something that people should be considering now?
Way to put me on the spot, Gwen. I think even just having a policy internally in an organization that really identifies actually, trauma-informed care, I think is a huge one.
Mm-hmm.
Incorporating trauma-informed care and recognizing that a lot of people who are coming into the situation either are coming in with a trauma history or may actually be traumatized by the experience itself. So minimizing the trauma that will occur. So I'm always a big advocate of incorporating trauma-informed, and also the youth-driven perspective. I think it's really important to have young people invited who have lived experience into governance structures, into evaluation, into quality improvement efforts, because young people who have been impacted by the system are going to be in the best position to articulate what worked well and what didn't work well. So I think actually inviting young people to sit into, like I said, quality improvement teams or evaluation teams is a really great practice that can improve outcomes long term.
I would also think asking for people's young adults experiences as they are leaving a certain setting, and then just not having them put it on a form, but being sure to incorporate it into that. Amanda, do you have additions to that?
Yeah, I'd be happy to share a treatment model and also a practice that could be institutionalized, I think, better at the local level for folks who have been civilly committed and or who are just seeking treatment, direct service treatment for their symptoms. Coordinated specialty care, so CSC, that is a recovery-oriented treatment program, particularly for people with first episode psychosis. So for what I experienced when I was in college. And the whole idea of coordinated specialty care, CSC, is that it promotes that shared decision-making and uses a team of specialists who work across disciplines. So this multidisciplinary team to create a personal treatment plan and to really offer that cross sort of pollination of expertise and specialists to care for that young adult. So it's really kind of a one-stop shop model instead of having to, I know for me, at least in my experience, it was very much a fragmented system of trying to navigate occupational therapy support, physical therapy even. The side effects from medication had physical and occupational effects as well. So it wasn't just a mental health issue, now it was an occupational and a physical health one as well. And so, and even nutrition and things like that. So practical teams where it's really what the CSC approach is for trying to provide that coordination across disciplines. So that's a really important one, but I know New York is doing a lot of important work on that. On Track New York in particular, as part of Columbia University Psychiatry, they do a lot of work in the coordinated specialty care model. So we can learn from a lot of different states what they are doing and try to maybe implement or advocate for that at the local level so we can have a more one-stop shop approach to treating folks.
Thank you, Amanda. As I was listening to you, I pulled out what I heard to be really important, which was hope, choice, and having allies, both family and other supportive adults. And I think CSC really tries to incorporate all of those things into that.
Right.
And then, Kristen, you certainly added the being trauma-informed and culturally aware.
Yes, and I think as I was listening to Amanda, another thing that popped into my head about a practice that can be incorporated is really peer support, right? Young people have a tendency to kind of seek informal support before they seek formal support. And so I think peer support can be a really good bridge to that and to creating engagement and to creating kind of a more low barrier access approach to the mental health system, which can be a little bit scary for some young people who may be system weary.
Kristen is quoting something we talk about a lot about being system wary and system wary. So Ivan just typed in the chat box about the intersection between communication technologies and the way young people navigate civil commitment. And thank you, Ivan, for bringing that up, because we know that young adults get the majority of their information from different technology sources or from their peers. Any thoughts on that, Kristen or Amanda?
This is Amanda. I can speak to just my personal experience with when I was civilly committed. This was now 2010, so I was 18 at the time. And back then, we didn't have iPhones then, and technology and telecommunication wasn't as big as it is now. And I remember the first thing that occurred when I was civilly committed was taking away the flip phone and taking away any sort of type of communication or any items. But I can imagine now if I was committed and my iPhone was to be taken away, which a lot of times for youth, these devices are an appendage to their self and their identity. I can imagine that would have been really traumatizing, and it would have been very difficult. However, there's certain protections in place against also having those devices in these systems. So it's sort of a slippery slope, and I don't have the answer or know the laws about this off the top of my head locally, but it's an interesting point that you bring up, and I think one that I'd love to hear other folks' thoughts and understandings about it as well.
I just pulled up some things I had been looking at earlier today. One's from the Pew Research Center that says youth are using technology for information gathering and communication constantly, and that this is from SAMHSA, are accessing mental health information and support via technology. So once again, thank you very much, Ivan, for bringing that up. And I agree. My understanding, Amanda, is that technology is often taken away when there's a commitment of any kind. And so that's probably a policy aspect to be looked at, and even if we have evaluators there, something to be evaluated of what are the pros and cons around that.
Right, and just to add a further thought to that too, is in terms of prevention and early intervention, I think technology and the use of devices such as a smartphone can be huge access points to preventing and educating, and to Kristen's point, mental health literacy. So how that intersects with media literacy. It's a huge, growing, booming field at the intersection of technology and mental health, and how we can intervene early and how we can identify markers, whether it be through text message or passive data or biometrics, and there's lots going on with that. As far as civil commitment, though, again, I can't speak to the laws or the practices around that, because they believe it would change according to what, where you are committed to and the laws there. But as far as a general community and just practice, how do we use these devices to promote pro-social behavior and help-seeking behavior, even for friends and family as allies and peers? So it's a very interesting and I think a super important topic. I'm really glad that you raised it. Thank you.
And you brought up another important aspect, Amanda, and that is the availability of peer-to-peer support and how important they are. And if someone is really relying on peer supports and, again, is committed and a phone is taken away or access to those peer supports, what are the policies and the procedures that continue to provide those peer supports while hospitalized? Okay. Amanda and Kristen, any final thoughts? Well, then I get to speak last, and that is to let you all know that today's session has been recorded, and it will be available to access on the web page within a couple weeks. If you want to learn more about the topics we covered in this session, please reach out to the Pacific Southwest Mental Health Technology Transfer Center on the website for additional resources. We would love to have your input on how we can best support your learning with different things in the field. Oh, there we go. Thank you very much. And here's an upcoming webinar we will also be hosting as part of the supports for those of you working in the field with youth and young adults. Kristen will also be a part of that webinar. And finally, and very important, the ability to continue doing these no-cost trainings depends on feedback forms from our participants, and we would really like that from each of you. It's required to use by our funder, and it's quick and it's easy to complete. It'll be on your screen after the session ends. It's a little tricky because the form uses the term addiction where it should read mental health. And please, when you see the term addiction, respond based on the focus on mental health. The funder's not able to update the form with the correct items at this point, but it will help us continue to improve what we're doing. Thank you. And we look forward to your feedback and seeing you again at another one of the webinars. And again, a big thank you to Kristen and to Amanda.
Thank you, everyone, for joining.
Thank you, everyone.
Bye, everyone.